Hello, my name's Dr. Matt Caporn and I'm a physician from the UK, and I'd like to present our poster which is entitled Efficacy of an Intermittent Energy Restriction Diet in a Primary Care Setting on Cardiometabolic Health and Glycaemic Control. Intermittent energy restriction is often referred to as intermittent fasting, and it's increasingly popular as a form of weight loss. But at the time that we did this study, nobody had actually examined the feasibility and efficacy of this type of diet in a long-term study in a clinical setting. And so we wanted to choose a primary care-based centre to actually look at this. And our aim was to compare an intermittent energy restrictive diet with a traditional continuous energy restrictive diet and look at the effects on weight loss, changes in anthropometry, but also on cardiometabolic health risk factors. And it was chosen to do this on patients with obesity. This was done at the Rotherham Institute for Obesity, which is a specialist weight management centre in the UK for obese patients. And all participants have been referred by local practitioners into the centre according to their referral criteria. So we did actually add some additional inclusion and exclusion criteria just for the purpose of the study, because we wanted to look at patients between the ages of 18 and 65, not outside those limits, and also to exclude patients with mental health disorders, learning difficulties and severe medical problems in case these were confounders with the results. But otherwise, patients accessed all of the standard care that the Rotherham Institute for Obesity offered. They were able to access the on-site gym, on-site cooking facilities, specialist nurses, dietitians, but they weren't allowed to engage with any weight loss medications or any other dietary interventions other than what they chose as part of this study. And interestingly, we didn't randomise the patients into one arm or the other because we felt that this would not reflect everyday clinical practice where patients can actually choose what type of dietary intervention they have. So patients are allowed to pick whether they went on the intermittent fasting or the continuous energy restrictive diets. Those who chose intermittent energy restriction had 5 days of the week where they were encouraged to try and stick as close as possible to their energy requirements on those days. On 2 days of the week, they were encouraged to have Lighter Life food packs, and Lighter Life is a commercial weight loss provider of very low calorie diet products in the UK. This enabled us to standardise the energy restriction down to the same 600 calories for all of the patients, and also provided nutritional completeness and prevented any possibility of nutritional deficiencies because Lighter Life food packs are total dietary replacement. Patients were allowed to choose whether they had their 2 fasting days next to each other or split by 1 or more days, and we accept the fact that this might be another confounder in the study results, especially when it came to patient satisfaction and nutrition rates. But if we now look at our flowchart for the study, we can actually see that we did well in recruitment. We wanted 100 on each arm of the study, and we got 99 in the intermittent energy restrictive arm and 98 in the continuous energy restrictive arm. At baseline, weight, height, body mass index, waist circumference, blood pressure, full bioimpedance, and 7-day diaries were completed, as well as some baseline bloods which included full lipid profile, fasting glucose, C-reactive protein and insulin. Now the full anthropometry was rechecked every single month throughout the 6-month intervention, and the bloods were repeated at baseline, week 4, month 3 and at the end of the 6-month weight loss intervention. And at month 3 and month 6, participants filled in the validated 7-day diaries once again. Now, if we look at our baseline characteristics, despite the fact that patients were able to choose which arm they went on, we can actually see in this table that both arms were surprisingly well matched between the two, with a starting weight of over 100 kilos in each arm, with about 109 kilos in the intermittent fasting arm and about 112 kilos in the continuous energy arm. We did tabulate all of the results here, which may be too difficult to see, so I'll summarise it for you. Now, unfortunately, we were disappointed with the attrition rates, because normal published data for the Rotherham Institute for Obesity is an attrition rate of 50% at the end of a 6-month weight loss intervention. Here, we found that only 27 of those patients on the intermittent fasting arm completed and 33 on the continuous energy restrictive arm. And we don't really have any robust data to explain why that was. However, what we do have is the results of the weight loss, and there was statistical significance between the two arms, and the fasting arm was better, with a result of 5.4 plus or minus 1.1% weight loss, compared with the continuous energy restrictive arm, which was 2.8 plus or minus 0.6% weight loss. When we actually looked at the cardiometabolic risk factors, the reductions in fasting insulin were comparable between both arms, and subgroup analysis of those patients with type 2 diabetes actually showed that all measures for glycaemic control were not statistically significantly different at all. Within the fasting group, HDL cholesterol increased and triglycerides were reduced, but this wasn't statistically significant. And although relative reduction of systolic blood pressure was seen in the fasting group, there were no statistically significant differences in the diastolic arm. So, in conclusion, what we can actually say is that the results provide preliminary evidence that intermittent energy restrictive diets can be a very useful tool, especially for weight loss in a primary care setting, in clinical practice in patients with obesity. What we now need to do is go further and repeat the studies with more patients and perhaps look at individual cohorts of patients such as those with type 2 diabetes. What we also know from this study is that intermittent energy restrictive diets are certainly not inferior in terms of the cardiometabolic risk factors. Thank you for listening.